since we have finished on time, probably we have time for a few questions, and if there are any questions from the audience. Yes, sir?
Amit, in the past we used to do the single chamber pacing, and we used to see this tachycardia induced cardiomyopathy. But now you are saying that even the dual chamber pacemaker can lead to a tachycardia induced cardiomyopathy. So therefore, it is not due to the loss of atrial kick which was responsible for the left ventricular dysfunction, but is it possibly because of the width of the QRS complex?
Yes, sir. So I think the pacing-induced cardiomyopathy is because of the location of the pacing lead. The pacing lead, conventionally, we used to put in the RV apex. Last almost decade, we have realized, and therefore we have been putting it more basally in mid-septal region. But despite that, the QRS is LBDB morphology. We still capture the endocardium of the right ventricle septum, and the QRS often is in the range of 140 to 160 millisecond. So it's a wide QRS LBB morphology which leads to dysynchronous contraction between the two ventricles and within the left ventricle septum and the free wall, which translates in a select group of patients into a clinical challenge in terms of LV dysfunction and heart failure symptoms, which to the best of my, though the literature would report 10 to 40% of patients, I would set an average probably around 15-20% of patients when you follow up on a long-term basis will lead to development of pacing-induced cardiomyopathy. So atrial kick was important. Single chamber pacing would have much more chances of pacemaker syndromes, as we call it, as a part of their heart failure symptoms. But the right ventricular pacing is definitely a concern.
Vinita, you went from this jugular. I saw your wire getting into the pulmonary vein. Did you do a septal puncture?
No, sir. I went into the pulmonary vasculature through the jugular route. I went into the RVOT to the pulmonary vasculature, and I parked my wire.
Oh, you went into the pulmonary artery, so it was not in the pulmonary
yes,
vein.
Pulmonary vasculature. No,
Oh,
not in the vein.
okay. I got you wrong,
No, sir,
possible.
not in the vein.
Okay,
Pulmonary
it
artery.
was in the pulmonary
Yes.
artery.
I found it much safer, sir, because I was very scared to, dilate it. When you are dilating it, you are pushing actually on that stiff wire. And RV, it would go through and through. So a lot of thought process went off how to do it, how to dilate it. Then I parked it there and I was good with it. Then it went on very nicely.
By the way, she was my proctor for my first micra.
Thank you, sir. Thank you. Thank you. I have had a privilege of, sir, Micra has put me in association with you all. I've done the case with you, I've done the case with Dr. Satyavan Sharma, Dr. Nihar, and these two wonderful guys. We've done a case in KEM, done 2 cases in HN. So it is wonderful. I mean, I am thankful to this modality of pacing, It has put me in direct contact with you all. Thank you so much. Thank you so much, sir.
Amit, can I ask a question? Actually, the question can be taken by any one of you. There are some patients, atrial fibrillation with slow ventricular rate. In fact, this is one of the patients which I am dealing with currently, has a coronary artery disease. The left ventricular ejection fraction is in the range of 45 to 50. His ventricular rate at times goes to 30. Actually, Amit also has seen him once, twice. Now, this patient is very keen that, he should get some type of pacemaker. Now, whether he should get a leadless pacemaker, whether he should get a left bundle side pacemaker, his ejection fraction at the moment is mildly reduced. So what will be sort of pacing modality for such a case?
So I think if I recount the things you said, he has atrial fibrillation, he has LV dysfunction which is mild, and he has a ventricular rate which goes very slow, suggesting that he has some kind of a high grade AV block, maybe paroxysmal. So he definitely requires a Brady pacing, and he already has some LV systolic dysfunction. So these are peculiarly the patients. If I assume he has paroxysmal and persistent AF, I would suggest a dual chamber. If he has a permanent AF, then I would restrict with a single chamber. Let's assume it's paroxysmal and persistent, so we are doing a dual chamber pacemaker and trying to maintain sinus rhythm with drugs, with cardioversion or whatever. And in terms of ventricular pacing part, this is peculiarly a patient where, as electrophysiologists, would be enthusiastic to do a left bundle area pacing. By giving a narrow QRS, we hope that we don't worsen the cardiomyopathy or worsen the LV systolic dysfunction. Obviously, in this case, there are many issues like the coronary artery disease and previous infarct or whatever, but this is the particular patient where we don't want to induce and pacing induced LV systolic dysfunction. With mild dysfunction, the decision to do ICD would be very individualized, probably not if he has mild LV systolic dysfunction, if the scar is small or something like that. So probably this is the case we would restrict to a dual chamber pacemaker with left bundle area pacing kind of a schema.
Thank you.
Madam, how do you decide the site of placing the leadless pacemaker? Can it get dislodged?
Okay, sir, first of all, when we are implanting the leadless pacemaker, we go towards the septum, we don't go to the RV apex. And septum site we confirm by giving dye that there are good trabeculae. Okay. I generally go to either mid septum or mid to high septum junction. I don't go towards the apical septum. Earlier I used to go towards the apical septum, that is how we were trained, but we learned that we have good trabeculae in the mid septum and mid to high septum also. So if I find good trabeculae, I put in the tines there and I implant the leadless pacemaker. Now following that is the most important step, that we have to do the tug test. We pull the tethers, it is attached with the thread that we call as tethers, and we pull that thread and see the movement of the tines under fluoroscopy on magnification as how those tines are moving. Out of 4 tines, if we see more than 2 tines moving, then it is very nicely implanted and it will be 15 times the force required to remove it. So this tug test is very important, and we do it in different views to see the different tines, so that once we remove the tethers, we cut the tethers, then it is finally implanted. There have been initially, sir, there were some case reports of dislodgement, but I mean, fingers crossed, Ganpati has been very good to me. I haven't had that problem yet.
Thank you.
We might have to.
Yeah,
Okay,
just one
Raj,
question. Dr. Amit, just as you have the RV pacing induced cardiomyopathy, do you have pure LBBB induced cardiomyopathy? And how do you confirm it is due to LBBB? And would LBBB pacing help these patients?
Yeah. So I think every patient with left bundle branch block should be followed up closely, because today his ejection fraction may be normal, but many LBB patients, they will eventually lead to dysynchronous contraction, which is there because of LBBB, will lead to a clinical situation where the LV function will go down and heart failure symptoms will happen. So it's recommended that every LV patient be followed up very closely on a 6-monthly basis for their LV function status, likely to deteriorate. And yes, your second part of the question, if that happens, definitely pacing with a biventricular pacing modality is a solution.
But if the patient has come late already with cardiomyopathy, how do you know it is not primary cardiomyopathy versus LBBB induced cardiomyopathy?
Yeah, so that is always a problem, which came first. Now, if you have a very typical left bundle branch block morphology, and if you had past records of LV function status, indirectly you can say. But generally speaking, typical LBBB, it is very likely that LBB came first and cardiomyopathy came later. But yes, it could be the other way around, especially if you have an atypical nature, wide QRS, or there are not the non-ischemic variety, but the ischemic variety, then you know that it's probably LV dysfunction which eventually led to the bundle branch block.
So let us wind up. This can go on the whole day. I thank the speakers, and we'll move on to the next question.
Thank you all speakers, respected chairpersons.